Good evening. It's a pleasure to be here. I want to talk a bit about the standardization and the need for standardization in the medical cannabis world. Why do we need to standardize or to regulate the market? Because a lot of people talked here. I heard my colleagues saying, I'm raising my own, I'm growing my own. Why do I need any regulation or any standard? First of all, it's a reduction to stigma. Secondly, not all patients can grow. When we started in Israel, the debate, or not a debate, when we started to have governmental permits for people to use cannabis, a lot of the patients, mainly cancer patients, came to us and said, what do you mean you give me a permit to grow? I can't grow. I can't wait 6 months for my first yield. I'm sick. I don't have the time to work in the garden. I don't have the energy. I want my cannabis. I want it as soon as possible. So we had to have growers to start growing for all the Israelis. It's also about easier access to patients, as I said, because not all can grow for themselves. When we talk about export and import around the world, if you have, for instance, like my previous colleague stated, a very good strain of cannabis being grown in Holland, and you want to import it, whether to Czech Republic or to Israel or to the US, you need to have permits. Without non-standardization of what you yield, you cannot have governmental permits. And lastly, but not least, is expanding of the knowledge among the health workers. When we doctors talk together, we need to have a language between us. And when we talk at this point, cannabis is cannabis is cannabis, we don't really know what we talk about. Because when we say a patient, a Crohn's patient, needs to have cannabis, we want to know how many times a day, what percentage of THC, what percentage of CBD, is the terpenoids important. For all this, we need to have standardization. First of all, the standards has to be among the manufacturers, what are the effective and stabilized strains that are ready for world distribution. And again, I know it's by trial and error that we start treating patients. We never know exactly what's the strain needed for the specific patient. Personalized medicine is already a proverb among medicine at large, but even specifically when working with cannabis, you have to know eventually which strain is the best for the patient that is being treated. But it takes time. And usually we start with a known brand. In Israel, it's usually a 14% THC, and work from there to see if we need to lower the THC content, to increase it, and what CBD content we need. We also have to have R&D standards. Remember that giving new strains to people needs to be officialized by what we call in Israel the Helsinki Convention, or internal review board, because it's doing science or doing tests on human beings. And lastly, again, is the manufacturing standard. Which one shall we obtain? The ISO, the good manufacturing procedure, or only good agricultural procedure? Remember that if you want to talk about medicine, GMP is required. The problem with GMP is it's very costly. And yesterday, one of the colleagues here talked about the price of cannabis and how much it is expensive for the patients to buy if it's not within the sick funds or the health funds in a certain country. Putting it under GMP standards, of course, increases the cost. And again, it's something you have to take in consideration when you decide which standards to use. Packaging, labeling, and leaflet have to be the same if you want to go worldwide, because people need to know that the things that they get are the same. It's easier to see if the packages are the same, and the labeling to know where do you read the side effects, and where do you read the amounts, and where do you read the indication will be on the same page, and again, within the same words. I already talked about the CBD and the THC content. What about the etiologies or the indications? This is extremely important when you talk within physicians. I would like to talk to my companion in the States or in Europe, and I want to know that we talk about the same indications. There will be debatable indications that will be acknowledged in one country but not in the other. But I think there's enough knowledge now to have at least those indications written on the board that everybody agrees on. Because chronic pain is a symptom that is alleviated by cannabis, Boaz here talked that it's better than opiates because it has no ODs, and usually the side effects are even less. Orphan diseases that have no other option of treatment, and all the other diseases which are already known and should be accepted worldwide. It's important again because if we have a specific strain that we think works better for MS patient, again, if it's accepted worldwide, it will be easier to export and import and access to the patient. From the physician's perspective, at this point of time, unfortunately, physicians usually know less than the patients on how to use cannabis. And it's, I think, the only medicine that the physician gives and tells the patient, okay, go to your friend and learn how to use it. When we give insulin, for instance, and the patient needs to inject it, usually we have a nurse, either he's coming to the clinic or the nurse goes to his home to teach him exactly how to give a subcutaneous injection. While with cannabis, at this point of time, mostly there are no instructions. In Israel, already instruction is mandatory, and you have to understand there's a big difference between taking cannabis for recreational use and using cannabis for medical purposes. For recreational use, you don't really care if you have a small side effect of nausea or of a headache or vertigo. You're on the couch, it will pass away. If you're going to work, it's important. If you have to drive, it's extremely important. The method of use is something we would like to know and would love to standardize. Boaz talked about smoking as the most efficient. I don't think it's the most efficient. I think inhalation is better, or vaporizing is better, but it's the quicker way, the most quicker way to do a titrate of how much you need. But afterwards, changing it to oil, especially in chronic pain, is usually much more beneficial because oil works longer. So you can take it fewer times a day, and besides, because of the stigma, going with an oil bottle in your pocket and taking drops a few times a day is much less stigmatizing than smoking. Dosing procedures, how many times a day do we take? How much? 1 cigarette, 1 gram, 2 grams, 2 grams of what? It's important to have a training in this. Our main object, or main way of dosing is you start low and you go slow. You want to find the amount, the smallest amount that is effective. You don't want to go up above a certain amount, because as far as we know, in cannabis there's an inverted U-curve response, which means up to a certain amount, the results or the success rate is better. Above a certain amount, it's either the same and you have only the side effects, or sometimes the success even lower, the success will go low, and you have actually the patient condition worsens. An important question in medicine is how to terminate, how to stop a treatment and when. If we have a Crohn patient who got better, he's 3 years on treatment, he doesn't have any pain, he doesn't have any diarrhea, should we stop or should we continue? Cancer patients, if they're in remission, should we stop or should we continue? If there are worse side effects, it's obvious we stop. Okay, but if there are no side effects, it's not as different as we think from other places in medicine. I'm a psychiatrist by profession. A lot of time when we start antidepressive for depression, and usually if it's the first episode, we want to stop it after a half a year, the patient a lot of times says, I don't want to stop it, I don't want to get depressed again. And it's a question of whether what we do. It's the same here. And of course, managing side effects. There are severe side effects that indicate the stopping of the medication, but there's less severe side effects, as I said before. Vertigo, nausea, some paranoid feeling even, that you can treat easily by lowering the dose or giving a Coke or saying to the patient, lie down for a few minutes, it will pass away. But the physicians still have to know about it, and at this point of time, unfortunately, they do not know enough. From a broader perspective, on one side, it's a very good treatment that people benefit usually greatly from it, and it's higher safety we already talked about. On the other side, it's mainly the pain killing, and Boaz hinted on that at this point of time, since in Israel at least, using cannabis for recreational purposes is illegal, A lot of pain clinics feel that people come to take the medicine for no true medicinal reason, and they feel pressurized, and that's why they stopped prescribing cannabis in Israel, which is actually very bad, because a lot of patients with chronic pain could benefit from cannabis and don't get any cannabis due to this reason. For the patient perspective, I will not repeat myself on the first two, but you must understand that cannabis has a different mechanism of work. I will not elaborate, it's a discussion by itself, but it can help where other medications did not work, if it's a last resort medication, and if it will become eventually a first line, it's still something that if this doesn't work, you have another option. Remember, even in cannabis, like all other medicine, 80% of the people do react favorably to it, but 20% will need another medication. Not all people are benefited from using cannabis. The other point the patient usually asks is what strain to start, what strain to use. In Israel, we have 8 growers. Each one says his strain is the best for whatever reason, and the patient has to decide what to take. This is something that if will be standardized, and if we know the content of each plant, and we know what helps what, we can help the patient decide. Always eventually it will be his decision. Again, even in psychiatry, whether it takes this kind of antidepressive or the other kind of antidepressive, an SSRI or an SNRI, it will be eventually the patient decision, but with the physician or with the psychiatrist helping him to decide. Should self-growing be allowed? I believe not, because as I said before, you can't standardize a self-growing plant. You sometimes have bad harvesting, and you need to go again to the shop to buy what is there. And the previous colleague talked about molds and the Escherichia coli and other contaminants that sometimes you have in home-growing plants, which you don't have in industrial plants. But my main point here is the training and teaching of patients and of doctors is mandatory, and I can't state how important it is. Because at this point of time, the patients do not know enough, they don't know enough on the different use, as I said before, and the physician don't have enough material to work on and not enough knowledge. What we propose is this flow chart, which a request is submitted by a specialist or a prescription is raised. It's processed by the medical cannabis center. A permit is issued to the pharmacy to buy and get what is needed. A letter or a phone is sent to the patient to come to a specific pharmacy where he can get what he needs. If there is a denial to some reason, it's also being sent to the patient and to the physician. Growers are chosen by tender, at least in Israel. It's not mandatory. It depends on every country. But the Cannabis Agency, according to the UN Convention, purchases all the product from the growers, and it supplies the pharmacy. As a physician, I'm against direct contact between the growers and the patients, because usually if a patient does not, a specific strain of the certain grower is not beneficial for the patient and he stays within the same grower tries to persuade him to change to a different strain that he still grows, or to ask for higher dose, and this will be effective, while maybe his neighbor or the neighbor grower, okay, a different grower will have a better strain for this person. While if all the strains are under the Cannabis Agency, the patient can decide what to go. In our vision, at least for the beginning, there will be a one-stop shop that has all the strains, and until the patient is fixed on a certain strain that helps him, he wouldn't have to go to the pharmacy. Only when he knows exactly what he needs after a brief trial and error period, then this will be sent to his pharmacy near his house. The distribution of cannabis can be in different ways. We believe that pharmacies are the best option. Of course, home delivery is an option. And the place for special dispensaries, I said, is only for the beginning of the treatment, as a one-stop shop, to have all the strains in the same country for the patient to decide with the help of his physician which is best for him. I think I've already talked about education and training, and I can't stress how important is this. But we believe that the health workers should be the main source of instructors and not patients. Not patients per se. If they are health workers, there's no problem. And we are now in the work of building specific programs for physician and medical staff, for consumers, and for policy makers. We believe that nurses have to be the major source of instructors, like it's done in all other venues of medicine, as I said, for instance, in diabetes. Of course, there are public health aspects that have to be addressed, but I think this is not the only medicine or treatment that has a potential of abuse. For instance, as if we're talking a lot about opioids, of all the opioids which have a high level of abuse, it's the fourth reason of dying, fourth cause of death among young adults in the United States. Use of prescription opioids. I'm not talking about heroin. I'm talking OxyContin and oxycodone. Okay? And even in Israel, we had a problem as farms as an environmental hazard because of the smell, because one of our farms was actually in the middle of one of the Israeli cities. In summary, because it's getting late, standardization and regulation of the global medical cannabis market, I think, is advocated and needed if we want to give better access to patients and better treatment to patients. Each country will, of course, build their own mechanism which will suit the best. But regulation, the idea of regulation, the basic standard should be worldwide. We propose to erect a global body that will cooperate and coordinate the work on these subjects for the future. Hopefully, this is what we hope to achieve within this Cannafest. Thank you very much for your time.
Takže máme prostor pro otázky.
Thank you very much for your wonderful talk, Dr. Baruch. I would like to ask you, in your flow chart of the logistic of patient supply, you mentioned that there is a necessity of so-called medical marijuana centers, like intermediate body between physicians and the agency and the pharmacy. So I just do not understand what the real functioning of this so-called medical cannabis center could be, because if they have a power to reject the recommendation of the physician, who is fully responsible in the medical legal sense to his patient safety, why it should we exist? Because, for example, in Canada model, it doesn't exist. In Holland model, it doesn't exist. And exists only in the Israel model. And I suppose this is just probably not necessary. And I suppose that you just need to explain this better. Thank you.
Okay. I will try to explain what we propose. First of all, according to the UN Convention, an agency, a cannabis agency, has to exist. The problem now, at least in most countries, also in Canada and even in Holland, where there is an agency, and of course in Israel, that the knowledge and the data is stored within the growers and not shared by the Ministry of Health or even the public. And that's actually a shame, because if we had all the data and knew by now, after 10 years of experience in Israel, what strains have been most beneficial to what diseases, because this data is in storage within the growers, we would have come already a long way. The point of whether or not permitting or allowing a patient or not allowing, this is a minor product of the agency. It doesn't have to be, as you said, in all countries. Okay, that's true. It's in Israel, and I would very much like to eradicate it. In Czechoslovakia, as far as I know, in the Czech Republic, as far as I know, they decided on certain specialities, and once you're a specialist in this field, you can give prescription, but which I think is very smart. You have to register in an electronic website, and all your prescription will be stored there. So the knowledge and the data, and probably the pharmacist will have also to store the knowledge there of what strain the patient got. So within 3 to 4 years in Czechoslovakia, they'll have the data to say which strain are more beneficial to whom.
Hello, doctor. You and others here speak a lot about the standardization of this whole system. But in a late study that Professor Hanush made in Israel, he found that he took the same mother plant, the same cannabis mother plant, 10 kinds of the same plant, and he checked the THC levels in each of them. And he found sometimes a margin of more than 15%. So I wonder how any medical cannabis, how can we standardize it without any stable strains? There is no.
I'll try to answer your question. It has to be a bit of technicalities. Okay, when you go into agriculture, you must understand that the strains are never the same. Okay, I usually give the comparison of a wine. In Israel, there's Ramat HaGolan, a place where we grow winery. But there's a lot of wineries. I'm sorry. We grow the raisins or and the vines for the wine, and they're still trying to make the same vine that has been the same harvest of 1996. Although they use the same vine, the same earth, the same pesticides and everything. We also know in Sri Lanka, when you pick the tea, you only pick the upper tea leaves because it's different around the plant. That's why we believe that. And I didn't want to get into it within this discussion. We believe that using oil is more beneficial than using the flowers themselves. Because as you said, the quantity or the quality of a flower will change between flower to flower, even within the same strain. Of course, in different harvests. And the patient will all the time have to decide how many cigarettes or how many grams a day or a week or a month he needs, because the quality will change each time. It's like, I'm sorry, I'll let you finish in a second. It's like if I gave you a paracetamol, which usually comes in a 500 milligram tablet, and I would tell you, I don't know how much it has. Sometimes it will have 1 milligram, sometimes it will have 1 gram. Take until the fever subsides. You would laugh at me as a doctor. In oil extracts, the main thing that is benevolent for us is that we know exactly, at least in the same batch, what are the ingredients that we checked, okay? In Israel, we now check 6 cannabinoids. We don't check yet the terpenes and the riboflavonoids.
6 cannabinoids out of more than 100, I guess. So it will never be really stabilized, never.
But even if again, I'm working in medicine. When you give hypericum for the depression, okay, in Israel it's called Remotiv. It's an hypericum extract. There's usually a target that's being classified and decided on the amount. It has an hypericin of 250 milligrams. The rest of the ingredients we never know. So we have to decide, eventually, we don't have enough knowledge, what are the main ingredients that need to be checked. We'll never be able to check, as you said, all the 135 cannabinoids and the riboflavonoids and the terpenes. Although there's a riboflavin called caryophyllene, which is a CB2 active. Okay? So we have to decide on a few things that we will measure and know exactly what they are. Hopefully, they will be the most important. Time will tell.
Další otázky?
Můžu poprosit trošku od toho reproduktoru, ono to jinak píská.
You're commenting on how a lot of the data for the best strains to treat different diseases was restricted, or the data has been kept by the growers. Is this because they see it as proprietary knowledge, or what do you think needs to be done to open up that wealth of information that does exist?
I don't know what is being done, okay? Hopefully they will open it from their own accord, even if they'll have the IP rights or whatever. We debated in the Ministry of Health during my time whether we should go to court to force them to give us the data. It was decided we don't want to open another front on the medical cannabis front already, okay? But if we are building in states that are building their medical cannabis project from anew, like in the Czech Republic, I would propose that from the beginning the data will be stored like they are doing here in the government or in the Ministry of Health.
Nějaké další otázky? Jo.